Hello and welcome to my YouTube channel. Continuing our series of some surgical emergencies which we have been covering in the past, today we are going to talk about a very important topic, one of the very common surgical emergencies which is seen in the emergency department, and that is a case of acute limb ischemia. So I've given a very apt title for this, Managing a Cold Blue Leg, which in effect means the underlying problem is a acute limb ischemia. Now, this video I am just concentrating mainly on the clinical features and the diagnosis. And I'm not going into the details of all the things because to keep the video short and impactful. So, without wasting further time, let's get started. Now, this is a classical example, the pictorial diagram of a blue leg which has become suddenly painful in a patient, maybe who has got underlying condition like atrial fibrillation, a patient on a prosthetic heart valve, or patient who already had a history of thromboembolic episodes. And he suddenly comes to the emergency department with a complaint of sudden severe pain in one of the legs, which has become slightly edematous, a blue, and which may show signs of sensory and motor involvement in the form of paresthesia, tingling, or some motor weaknesses like paresis or complete paralysis. Now, to understand this topic, I think it is very important to very quickly recap the lower limb arterial anatomy. If we start from external iliac artery, when it crosses the inguinal ligament, it becomes a common femoral artery as seen in this diagram. Now, once it enters into the thigh, below the inguinal ligament, it becomes a common femoral artery. This common femoral artery gives a one very important branch, and that is known as a profunda femoris artery or deep femoral artery. This deep femoral artery, which arises posteromedially from this, posterolaterally from this common femoral artery, divides into a very important branch, that is median and lateral circumflex femoral artery. This median and lateral circumflex femoral artery supplies the head of the femur, and the anastomosis at the neck of the femur, and that's why any fracture in the neck of the femur can lead to avascular necrosis because of disruption of this anastomotic supply to the head of the femur. Now, continuing down, once this deep femoral artery is branching off from common femoral artery, the common femoral artery now becomes a superficial femoral artery or SFA, and it continues down into the adductor canal and enters into the popliteal fossa as seen here. And at the lower border of the popliteus muscle, it becomes popliteal artery. Now, in the popliteal fossa, just below the popliteus muscle, it divides into three important branches. The one which supplies the anterior compartment of the leg is known as anterior tibial artery. The one which supplies the posterior compartment of the leg is known as posterior tibial artery. And then we have the lateral compartment supply, which is a fibula or a peroneal artery. So this is a trifurcation of a popliteal artery in the popliteal fossa. Now, this anterior tibial artery, if you see on the diagram on the left side, it continues down between the two malleoli in the midpoint, and then it is known as it enters into the foot, it becomes a dorsalis pedis artery. This dorsalis pedis artery is normally situated between the first and the second interdigital cleft, lateral to the extensor hallucis longus tendon. Now, this dorsalis pedis goes plantar side and takes part in the formation of the plantar arch. Now, coming to the posterior tibial artery, which supplies the posterior compartment of the leg, it goes behind. This posterior tibial artery would go behind the medial malleolus and again take part in the formation of medial and lateral plantar arch. So this is the basic, in a nutshell, the arterial supply of lower arterial anatomy, which is very essential to understand the case, which is a case of acute limb ischemia. Now, classically, all of you must be aware of the 6 P's of acute limb ischemia, and it is obviously a vascular emergency. And what is a clinical concept? A sudden, rapid decline in the limb perfusion that threatens the immediate tissue viability. So there's a sudden, it's a dramatic event, it's a sudden event where the patient, as I've already told you, would come with a sudden severe complaint of painful leg, which is blue, which may have some sensory or motor disturbances, and patient may have a past history of atrial fibrillation or a prosthetic heart valve or an infective endocarditis, or patient may be a immediate past case of thromboembolic episode or thromboembolism. Now, mind you, this is more or less a clinical diagnosis. So, a good history, a very quick good history should be taken, and depending on the physical examination of the affected limb, it remains one of the important vascular emergencies, and that's why no time should be lost in performing certain investigations, because the time is premium here, the time is precious here. So, without wasting any time, if a clinical suspicion is strong enough for a diagnosis of acute limb ischemia, then the patient should be taken for immediate intervention, vascular intervention, whether it is an endovascular intervention or a surgical intervention, to prevent this very, very important condition which can lead to the loss of limb or even life. Now, what is the six-piece checklist about the clinical diagnosis? A pain, which is a prominent symptom. It's a sudden, constant, agonizing rest pain. Okay, and the pain is described as severe pain. That means 8 or 10 out of 10 on the pain scale. It is a constant pain. It occurs even at rest. And if you examine the limb, the, the limb would be pale, pallor, chalk white appearance. This may be followed by some mottling in between. So this gives a typical appearance of mottling on a background of a pale leg. Number three is pulselessness. When you palpate the peripheral pulses like dorsalis pedis or anterior tibial or posterior tibial or popliteal artery, depending on where is the occlusion, there may be total absence of manual as well as Doppler pulses on color Doppler. Poikilothermia, that means it would be cold to touch because of ischemia and may match the ambient temperature. Paresthesia, there would be some sensory loss which indicates an advanced ischemia of the somatic nerves. And paralysis, last one is paralysis or motor loss or muscular weakness, which indicates a severe ischemia of the muscles leading to muscular death. So these are the six classical P's of acute limb ischemia, which should be used in the clinical diagnosis of acute limb ischemia. Of course, the C-reactive, the capillary refill time would also be prolonged in such cases. Now, etiology, if you see, of acute limb ischemia, we have a very common etiology of embolus as versus thrombosis. Now, most of the time it is an embolic occlusion arising from a source of embolus, which could be a thrombus or some mechanical or prosthetic heart valves, or a case of infective endocarditis. Now, how would you differentiate embolic occlusion from a thrombotic occlusion? Generally, in acute limb ischemia, embolic occlusion is more common. And as discussed before, it causes sudden hyperacute symptoms which can occur within few minutes, whereas a thrombotic occlusion is a more gradual acute on chronic process which may occur in hours or days. If you take a history of that embolism, then atrial fibrillation, recent myocardial infarction, occlusion is more of a chronic occlusion, then it can have a patient with claudication distance, peripheral arterial occlusive disease. Patient may also be smoker, especially in young patients. Contralateral leg may be normal, but there is even in the contralateral leg, because the underlying problem of atherosclerosis may be a systemic condition. Now, in embolic occlusion, the collaterals have no time to develop. So there would not be any collateral circulation, resulting in a profound severe ischemia. Whereas because thrombotic occlusion is more chronic, time taking process, the collaterals still have got time to develop. That's why in a thrombotic occlusion, we have a well developed collateral circulation. And this would mean that patient can handle the ischemia much better than a embolic occlusion. Now, one of the most important classification system which is used clinically as well as relying on the Doppler findings is a Rutherford classification. This Rutherford classification for acute limb ischemia is different from Rutherford classification for a peripheral arterial occlusive disease, which is more of a chronic occlusion. Here we are talking of acute limb ischemia, Rutherford classification. Now, it is divided into three important classes. And what is the importance of this Rutherford classification? It would help you in formulating a decision making, a treatment plan, what is to be done in a case according to the Rutherford class. So, class 1 Rutherford in acute limb ischemia, the limb is still viable. That is the most important thing. That means there is no sensory or motor loss in that affected limb. There are audible arterial and venous Doppler signals present on color Doppler. And such cases, because the limb is still viable, can be managed with immediate evaluation, like further evaluation like CT angio and further imaging before you plan a treatment. So here the it is an emergency, but it is not such an emergency that patient is at immediate risk of losing the limb. Class 2 is a threatened limb, and it is subdivided into 2A, which is marginally threatened, and 2B, immediately threatened. Now, 2A consists of minimal sensory loss in the toes, but there is no motor weakness. And on color Doppler, there is inaudible arterial Doppler, but audible venous Doppler present. So, arterial Doppler is inaudible, that means there is no signal on arteries in a color Doppler, but venous Doppler is still visible. Whereas 2B, which is immediately threatened limb, there is a marked sensory loss here, but again, a very mild to moderate motor loss. There may be paresis, and this is because it's a threatened limb. Here there would be inaudible arterial Doppler and a very weak venous Doppler. This patient requires emergency revascularization within a specified time frame of 6 hours. Otherwise, this patient can lose the limb. And class 3 becomes a irreversible. That means it is severe permanent anesthetic loss and complete paralysis with rigor or a muscular contraction. The venous and the arterial Doppler signals are absolutely silent. And such cases, because they are irreversible, the ischemic damage has already gone beyond a salvageable state. These patients may require amputation of the affected part to prevent further complications like sepsis. If you attempt to do a revascularization in such a case, there may be release of lethal toxins, which we will discuss, what we call as a reperfusion syndrome. So these are the three classes of Rutherford, which would help you in formulating a treatment plan for a case of acute limb ischemia. Now, what are the immediate interventions in reperfusion injury? A word about that. So the first thing when you do, mind you, it is a clinical diagnosis, as I've already mentioned. So the first thing you do is immediate heparinization on a strong clinical suspicion. So administer an intravenous unfractionated heparin bolus immediately, typically 5,000 units, followed by an infusion of low molecular weight heparin. This would prevent further propagation of the clot. So immediate heparinization is very, very important. Now, this would give you some time. Now, depending on what class the Rutherford is, for example, if your patient is, say, early stage, like class 1 or 2A, that means it is not immediately threatened. In such cases, we still have some time to do certain investigations. So, very quickly, a Doppler ultrasound, which is a non-invasive investigation, should be done in all patients suspected of acute limb ischemia. And the normal arterial signal in a normal patient is triphasic. Whereas when there is a diminished blood flow, it becomes monophasic on Doppler. And it may become monophasic or it may be totally absent, as in 2B and 3. So a monophasic or an absent signal is very strongly suggestive of acute limb ischemia. If time permits, and time would permit only in Rutherford class 1 and 2A, then CT angiography may be performed in such a case. However, no time should be wasted for CT angiography if you feel that your patient is unstable or you're losing time unnecessarily. Similarly, CT angiography has no role in Rutherford class 2B and obviously in class 3. So, in such cases, if time permits, go in for CT angiography, which would give you an exact location of the obstruction, the whether it is a multi-segmental obstruction or it is a single segment obstruction. It would also tell you the exact site, the inflow and the outflow. So all those information you can pick up on CT angiography. And the immediate revascularization should be performed in such cases, which can be done either endovascular or it can be done on an open surgery. If the facilities for endovascular surgery is available with a vascular surgeon, then embolectomy by passing a Fogarty's catheter, which goes past the clot. And once you inflate the balloon of that Fogarty catheter and withdraw it, it can pull out that embolic occlusion. And this is a very important procedure which can be done immediately once the diagnosis is made to prevent further deterioration in that case. Now, mind you, there is always a reperfusion trap or a reperfusion syndrome which you should expect in such a patient, because when the oxygenated blood suddenly returns to an ischemic limb after revascularization, this would build up certain you can say toxins like potassium, lactic acid, and myoglobin, which are released into the systemic circulation. This causes a typical crush syndrome like picture where there is a hyperkalemia, metabolic acidosis or lactic acidosis, and myoglobinuria. This reperfusion syndrome, with all these toxins, the potassium, the lactic acid, and myoglobin released into the circulation, can lead to acute kidney injury with renal failure, or it can even lead to cardiac arrest because of hyperkalemia. So, this reperfusion syndrome should always be kept in mind as a clinician, and you should be ready to tackle this. Now, this is what I was talking about the embolectomy, where the right femoral axis is gained, as shown here, and the Fogarty's catheter is passed beyond the embolus. The balloon is inflated, and when it is withdrawn, the embolus is also. So, this is withdrawn. So, this is one of the very important ways of tackling acute limb ischemia if the facilities for the same are available in your center. Now, just to recap, in a flow chart, if you have a patient of acute limb ischemia, do a quick history taking from the patient, if the patient is in a correct condition, to give you the history. Do a quick clinical examination, including general examination and examination of peripheral pulses in the affected limb. Check the sensory system, motor system. Examine the limb. If it is a pale with mottling, your diagnosis is more or less there. If time, all patients should undergo a Doppler evaluation immediately, a color Doppler, and based on that, based on your history, physical examination, and Doppler study, you would classify the patient into Rutherford classes. If the patient is Rutherford class 1, where there is a normal motor and sensory function, audible Doppler arteries, audible Doppler veins, then this patient's limb is still salvageable if treated promptly. So immediate heparinization, anticoagulation should be started, and then patient should be subsequently planned immediately for a revascularization procedure. If on clinical examination, history and Doppler evaluation shows a Rutherford class 2, which is like class 2A or 2B. If it is 2A, then we have a normal motor and sensory function, but inaudible Doppler artery, but audible Doppler veins. In such a case, the limb is still salvageable if treated promptly. Again, anticoagulation and emergency revascularization should be done. If it is Rutherford class 2B, there is an impaired motor or sensory function, inaudible Doppler arteries, but audible Doppler veins, the limb is still salvageable if treated emergently. Immediate anticoagulation and revascularization should be done. If it is Rutherford class 3, based on your evaluation, that means absent motor and sensory function, inaudible Doppler arteries, inaudible Doppler veins, then such a limb is non salvageable and immediate amputation should be done to prevent further complications like sepsis, because most of these patients may also have some other comorbid conditions, and patient can go quickly into sepsis and which can threaten the life of the patient. With that, we come to the end of this presentation. I hope you have liked this very high impact, focused management of a patient of acute limb ischemia. I'll keep on coming with such more high impact, focused videos in my subsequent series. If you have liked this video, please share with your batchmates, your colleagues, subscribe to my channel, and do give a thumbs up. Thank you for your time. Thank you for watching.